It is showtime.
The broadcast is now starting. All attendees are in listen-only mode.
A song to sing to help me cope with anything. If you see the wonder of the fairy tale, you can take the future, even if you fail. I believe in angels, something good in everything I see. I believe in angels when I know the time is right for me. I'll cross the street. I have a dream. Pushing through the darkness, still another mile. I believe in angels, something good in everything I see. I believe in angels, when I know that time is right for me. I'll cross the street.
Good morning, everybody. This is Dr. Minarcik, and who you just heard you might have thought was ABBA, but it wasn't. It was a group singing a ABBA song very nicely. All of the music today has been donated to us by one of our students, Raghi Mohammed, and some of the music we'll be hearing today is also Arabic music. So he submitted to us a nice combination of both Arabic and Europop, and we'll be looking forward to it. I have a big 49 on my clipboard today, which means that this is our 49th two-hour session in free global online medical school pathology, and it's 9 o'clock here in Chicago, and it's Thursday, and it's March 7th, and about half of the 10 inches of snow that we had yesterday have melted, and we have a bright sun today, and it's melting even more. I guess this is a good time to do a test now before we get into our major announcement, and even a little bit of pathology that we'll learn today as well. First question always is, do you hear me well? And I'm seeing a whole bunch of yeses. Good. And I'm hoping that Dr. August can see the yeses as well when I ask the questions. If she sees them, she can also respond to them. But the second question is, what do you see on your screen now? I'll give you a hint. It's not a myocardial fiber. Yes, everybody sees the fluorescent or neon butterfly. And now we're ready to rock and roll. I know that you heard the music very well. And now we can get into our big announcement before we start our topic. The big announcement is this. It's a good announcement. You know, I have always been very happy with the way things have evolved over the last 4 years of me doing these sessions online. And I've always thought of ways that they could be better, and most of the times when I make positive changes, it's because one of the students has suggested it. Sometimes they're based on polls, like the ones that I took last week. The only thing I felt that was severely lacking in the format of this course was another expert pathologist to answer your chat questions as they occur throughout the 2-hour presentation. The problem is, usually when I get on a roll and I'm focused in on a topic, sometimes I can see little flashes of chat off on the right side of my screen, but I don't get a chance to comment on them because I don't want to lose my chain of thought. Well, I was able to go onto the pathology forum here in the United States. It's called Patho-L Discussion Group, and find a very expert USA pathologist by the name of Deborah August. Dr. August, like the month, is here today with us, and I have just transferred organizer status to her, which means Dr. August can now read all of your comments and answers and chat questions as well. She is no longer just an attendee. She is now like me. She is a big honcho, okay? So this is what we can start to do now, and we've did it before. For those of you who have been here the whole year, remember we had another pathologist in the early part of this course that would do that, but then his schedule forced him not to be able to attend with us. So feel free to ask questions of any type during my presentation. You won't have to worry about bothering me because Dr. August will be there looking at your chat questions and answering them. I guess if they're not too tough, she'll answer them. If they're real tough, then they're probably really too tough for me as well. So I don't know if you could see this, Deborah or Dr. August, but you can see that a whole bunch of people, a whole string of people have welcomed you already. And you can certainly respond to any of them either privately or globally. That's your prerogative. You also have the power to shut this whole webinar down because you have the highest level of control now. It's called organizer status. So please don't press any buttons that you're not too sure of, or we're going to crash. Okay. That was a great announcement, a very positive thing. It was the only major thing that I thought would be great to improve this seminar. The topic for today is still heart diseases. If you remember, we've had 2 previous sessions on heart diseases. We covered most of the various categories of heart diseases, except for a pretty medium or good size category near the end called cardiomyopathies or myocardiopathies. The preferred term is cardiomyopathy. So we'll be talking about cardiomyopathies today, and then we'll also talk about Let's see. Then we will also talk about pericardial diseases as well. I hope that our PowerPoint opens well here. I could see it gave me a little bit of an error at first, and you probably saw that too. So here we are on the first yellow brick of the road leading to the wizard at slide number 1. But we had gone all the way down. Whoops. How about if we ignore that? Oh, yes, we will. We had gone all the way down past the endocardial diseases, the artificial valves. Here we are on yellow brick number 110 out of 130. We have 20 more steps to take before we finish the chapter. And then we will take perhaps an early break, and I've prepared approximately maybe about 10 or 12 slides for Pathology Lab. You can see all the slides over here. The thumbnails are like looking at the actual cut on a piece of glass. A couple of them refused to thumbnail, but they still work, I know that. And then, if we still have time, I will consider either starting the next logical topic in Robbins, which would be diseases of coagulation and red blood cells. But what I think I'll do instead is, assuming we can get done with myocardial diseases, pericardial diseases, brake, music, and heart lab before the end of the 2 hours, I think I would like to probably plead with you to plug in your microphones and let's have a good old-fashioned chat again. The one thing that we have been lacking in here is two-way mouth communication. All you have been hearing is my mouth, and all I've been seeing is your chat. So if you do have a Radio Shack microphone somewhere in your drawer there, just plug it in sometime in the first hour, and maybe we could hear some stories from your part of the world. Heart disease. The last major topic, heart disease, are primary myocardial diseases. Okay, those are called myopic, myopathic, or cardiomyopathic, but the real word for them is myocardiopathies, or cardiomyopathies is the preferred term. If you look in your Google and do some searching, you can see that cardiomyopathy is the preferred term. So on the left side of the screen here, you got about 6 or 7 things which we would call etiologic aspects of cardiomyopathies, are the kinds of things that cause them, including, of course, the one that we don't know what the cause is, which is always idiopathic. So I don't know if we should call this 6 or 7 categories. But another way to look at them is functionally and not etiologically. So on the right side of the screen here, you have the 3 functional categories of cardiomyopathies. In one of them, you basically have a dilated heart, not necessarily with hypertrophy, but primary dilatation. And the dilated myocardiopathies are usually defects that occur during systole, or contraction of the myocardial fiber. The hypertrophic cardiomyopathies, HCM, and the restrictive cardiomyopathies, RCMs, are usually defects which occur during relaxation of the fiber. And there's a really good way to separate all these with one very simple test, which we're going to get into. So you could think of them either in terms of etiology or function, and we're going to talk about both aspects of them. Here's a nice graphic of what we were just talking about. I guess if you take the upper left heart here as being normal with normal thickness, that's about 1.5 centimeters for a left ventricle. A dilated cardiomyopathy would mean that the chamber is dilated, or if you want to think of it as a volume, think of it as a large EDV, or end diastolic volume. The thickness of the wall is not necessarily increased. In a hypertrophic cardiomyopathy, the primary event is a very much thickened wall. So rather than 1.5 cms. It could be 2, 3, 4. And as a result of the thickening of the myocardium, you have a very, very small volume as opposed to the dilated cardiomyopathy. And the small volume is strictly a geometric reason. The geometric reason is that there's so much myocardium there it actually obliterates a good portion of the end diastolic volume. Now, if you remember that your ejection fraction, or left ventricular ejection fraction, is a calculation in which the end diastolic volume varies inversely with it, you might guess that if your EDV is small, your ejection fraction would be large. It's strictly mathematics. On the other hand, if you have a primary disease of myocardium in which there is loss of compliance, in other words, the heart muscle does not relax properly and fully. It relaxes stiffly. This is also a diastolic phenomenon. If the myocardium cannot relax properly and fully, that might also lead you with the situation in which the EDV is also smaller. Okay? So in diseases of myocardium, myocardiopathies, cardiomyopathies, in which your ejection fraction is large, it's either large because of anatomic encroachment of the thickened myocardium, or large because of failure of relaxation properly. In other words, a compliance problem. Just like we'll be talking about compliance problems with the lungs as well. Okay, so here's a little bit more of a functional definition here. I like the functional definition. In the dilated cardiomyopathies, your end diastolic volume down here is large because the heart is dilated. So that means the end diastolic volume is big. And if the EDV is big, the EF is low. Remember, the ejection fraction varies inversely with the EDV. Here's the actual equation on top if you want to see it. On the other hand, in the hypertrophic cardiomyopathies, the ejection fraction could be huge. Usually the normal ejection fraction is around 45 or 50%, but if it goes below 40 or it's up into the 60s, 70s, 80s, even 90s, you think that either there is anatomic encroachment of that volume by very much thickened myocardium, or a restrictive problem in which there is failure of compliance. Okay, there can also be compliance problem with hypertrophic as well, simply from the problem, from the phenomenon that it's very, very much thickened. Okay, so the biggest category, the dilated cardiomyopathies, we could go into a little bit of a list now. For example, alcohol, which is the biggest cause of cardiomyopathy anywhere, some of the genetic ones, some of the common ones due to chemotherapy, so-called adriamycin or doxorubicin myopathies, some of the infiltrative ones like sarcoid. These would all result primarily in a dilated heart. Now remember, don't think that these are all completely separate categories. In some of the dilated ones, you can also have some hypertrophy. In some of the restrictive ones, you can also have dilatation. So these are not totally separate categories. Okay, the dilated cardiomyopathies are systolic impairments. The hypertrophic and restrictive, because of the low EDV, are compliance or diastolic dysfunctions. Now take a look. You might say, well, why would infiltration by amyloid result in a restrictive, but why would infiltration by granulomas from sarcoid result in a dilated? Well, that's just the way it is. Okay, even though amyloid can infiltrate the heart, it doesn't necessarily make it thicker, and it doesn't necessarily make it more dilated. Now think about a pericardial constriction, perhaps a chronic fibrous pericarditis. Well, that would obviously result in a restrictive myocardiopathy as well, simply from the fact that there is a physical constriction to the proper relaxation of that heart. Or think of a situation in which there is aortic stenosis or hypertensive heart diseases. These are the obvious hypertrophic situations. In those cases, you might have, because of the extreme thickness of the myocardium, an extreme percentage of that end-diastolic volume being spit out or ejected with every beat. That's why the hypertrophics are also potentially high ejection fractions. Okay, so much for the functional differentiations. I'm going to give you more of a laundry list right now. And I don't really expect anybody to memorize this, but I am going to tell you that these are the things you might see in a textbook commonly without going into the common denominators. The cardiac infection, cardiomyopathies, can also be called myocarditis. Sometimes there is a very fine line of distinction between myocarditis and myocardopathy. Okay, probably most functional myocarditis can also be called cardiomyopathies as well. We know viruses could do it, especially the Coxsackie virus, especially the Coxsackie B virus, probably the most common cause of a viral hepatitis, of a viral myocarditis. Also, just as though we saw that chlamydia can wreak havoc on endothelium, chlamydia can also cause a myocardiopathy as well. Just as though rickettsia in Rocky Mountain spotted fever can cause a small vessel vasculitis, it could go into the largest vessel of the body as well, the heart. Certain bacteria, pyogenic, other bacteria, fungi could do it, protozoas can do it, either in areas where they're endemic or in patients that are extremely immunosuppressed. What about the neuromuscular diseases? What about Friedreich's ataxia? What about the muscular dystrophies, which involved not only skeletal striated voluntary muscle, but striated involuntary cardiac muscle? Think of that as also a cause for a cardiomyopathy. A lot of these are congenital. Most of the congenital ones are based on genetics, okay? What about post-transplant rejection, okay? In other words, host versus graft. You think that might result in a primary myocardial dysfunction? Absolutely. Several forms of autoimmune myocarditis have been described. The single biggest list and the single biggest cause specifically at the top is alcohol. But here's a little laundry list of things that have all been frequently indicted or associated with cardiomyopathy. Some heavy metals, arsenic, cobalt, the concept of stress myocardopathy or stress myocarditis from excessive exogenous or endogenous catecholamines, carbon monoxide, lithium, and of course the chemotherapies. The first one to be described was cyclophosphamide, but the single biggest one, also one of the most effective chemotherapeutic agents, adriamycin, you know, your doxorubicin, has to be given very, very caution to patients with impaired myocardial function, has a high association of myocarditis, myocardopathy. Some of the lysosomal storage diseases in which enzymatic substrates are not being processed and therefore stored, like Hunter-Hurler syndrome we mentioned, with the buildup of dermatan and heparan, some of the glycogen storage diseases, some of the glycolipid storage diseases, Fabry, amyloid as well. Think about them as being stored in the myocardium and therefore interfering with proper primary myocardial function. Okay, what about some of the metabolic diseases? Well, both hyper hyperthyroidism as well as hypothyroidism can have a direct suppressive effect on myocardium. Both hyperkalemia as well as hypokalemia, you know that the heart needs a relatively narrow range of potassium in order to work properly. Either too much or too little will interfere with its function. Some of the nutritional diseases, protein deficiencies, vitamin deficiencies, thiamine especially has been indicted, as well as hemochromatosis, buildup of iron pigment, hemosiderin, not only can load up the liver, but can also load up other organs and interfere with their function, particularly myocardium. Now, the ones that are, of course, easiest to understand anatomically and functionally are the infiltrative ones. Extensive leukemic infiltrates within the myocardium will interfere with its function. What about carcinoma metastases? It's not very common, but it happens, and infiltrates or metastases of carcinoma into myocardium can cause a myocardiopathy. We've already mentioned sarcoid as being one of the most common forms. I don't know if you'd want to classify that with an infection. You might call it an infection in which the etiology has not been clearly understood for many generations. What about a heart that is in the field of extreme radiation port, for example, let's say from a lung carcinoma? That's been described as well. So these classifications are just a common laundry list of things, mostly as an etiologic basis, that things have been linked to causing cardiomyopathies. And of course, the ones that we call infections also overlap massively with the category of myocarditis. I guess myocarditis in itself, a primary inflammation of the heart, can also be considered a cardiomyopathy as well. Okay, let's look at the most common type, the dilated. We said that there was chamber thickness increase, not just necessarily LVH, but the primary thing is dilatation of the lumen, of the volume. They basically have a progressively declining LVEF. The more dilated the end diastolic volume is, the lower the LVEF would be. That's simple mathematics. And also remember, the dilated can also overlap significantly with the hypertrophic. The prognosis of a dilated cardiomyopathy, and look, doesn't it look like these three things here are probably the most common forms of cardiomyopathies? We said alcohol was at the top of the list. Adriamycin, any type of myocarditis, will result in a dilated cardiomyopathy, theoretically. As the LVEF decreases, so does the prognosis. And overall, the statistics, somebody with a dilated cardiomyopathy does not have a very good prognosis. The hardcore statistics is that half of them die in 2 years. Okay, here's a dilated cardiomyopathy. You can see in this chamber the left ventricular volume. You don't know if this is systolic or end diastolic simply because it's an autopsy specimen, okay? You can see that the thickness of the myocardium does not look massively increased. It may be a little bit increased. Also notice that there's some increase in thickness of the right ventricle because cardiomyopathies involved all myocardium, not just necessarily left ventricular. And with dilatation of that, you may see a small amount of interstitial fibrosis as well. You can see a little sprinkling or scattering of some increased fibers here, collagen fibers, which are stained green by the trichrome method. Now, I just told you that most dilated cardiomyopathies, in fact, I think I said all, are generalized to all myocardium. I kind of lied a little bit because you should probably know that there is a dilated cardiomyopathy that is fairly specifically limited to the right ventricle and the right side of the heart. And this goes by the name arrhythmogenic right ventricular cardiomyopathy. Sometimes they use the word dysplasia, not meaning pre-malignant, but probably impaired function. And here's a bread loaf section or an axial section through the heart. You can see a pretty normal, thick, perhaps even thicker than average left ventricle. But look how dilated this right ventricle is, okay? So that would be a nice question about what type of cardiomyopathy is limited to primarily the right heart rather than being uniform. There's also a syndrome called Naxos syndrome, N-A-X-O-S, which this is associated with, and it's a genetic disease, and people with Naxos syndrome, not only do they have this arrhythmogenic right ventricular cardiomyopathy, but they also frequently have woolly hair and very much thickened palms and soles. Let's see if I could open that up a little bit, if it'll let me. Oh, apparently it won't let me because it doesn't like the one that I did. So you just have to look at it in a small way here. Let's move on to the next one. The second category of myocardiopathy, like the third, is also a primary dysfunction during diastole rather than systole. Okay? The term hypertrophic cardiomyopathy has been more or less synonymous with the term that was used a generation or two ago, commonly called IHSS, standing for idiopathic hypertrophic subaortic stenosis. Okay? And because it's a subaortic stenosis, you can guess that the left ventricle will be extremely thick, partly because of the stenosis. But even though the term is called idiopathic, we now know that most cases of IHSS, or hypertrophic cardiomyopathy, are genetic diseases due to defects in gene which code or build various parts of both the actin as well as the myosin chain. For example, there might be a genetic defect in the beta myosin heavy chain, or something in the actin chain, which we saw the other day, called troponin T, or alpha tropomyosin, or myosin binding protein. So genetic defects resulting in the faulty production of these components of cardiac muscle could very easily result in IHSS. And because the muscle is not properly formed, because there's also a stenosis subaortic, you can imagine an extremely thick left ventricle. And if your left ventricle gets very, very thick, it impairs with the volume of the end diastolic volume of the heart. And remember, the smaller your EDV is, the larger your ejection fraction is. Now remember, the ejection fraction is purely a ratio. It's just a percentage. That's all that it is. So even though they have a very, very small EDV, they also have a small or reduced stroke volume as well. They also have a reduced chamber volume, which is your EDV. And they have a problem with diastolic filling. So remember, this is a case in which the stroke volume is small, but the ejection fraction is also small based on the fact that the EDV is very minor. And I have personally seen many cases of this in nuclear medicine, not uncommon to have an ejection fraction into the 80s or 90s. I mean, it's just very, very largest ejection fractions you'll ever see are probably with IHSS. Okay, now our third and last functional category of cardiomyopathies are called the restrictive cardiomyopathies. And once again, we see the word idiopathic here as well, meaning relatively unknown. But when you see the term restrictive, think of a decrease in ventricular compliance, okay? So a ventricle that has reduced compliance cannot relax as well as it should. As a result, it's also possible that these patients will have large ejection fractions, but generally speaking, the chamber size and the wall thicknesses are about right. Now, one big category of the restrictive cardiomyopathies are certain types of relatively rare conditions. For example, an endomyocardial fibrosis, seen very often in African children, or an eosinophilic leukemia infiltrating might cause restrictive changes. And finally, there's another idiopathic condition called endocardial fibroelastosis. You might think it's primarily the endocardial aspect that you can see in kids. They would also call it restrictive as well. Now, restrictive from a functional point of view is more than just a little list of things that constitute a restrictive cardiomyopathy. If you could think of any infiltrative disease in that myocardium which would interfere with its proper diastolic relaxation, you can guess that that would also be considered a restrictive type of cardiomyopathy. So when you think restrictive, think compliance. Okay, we're done with the so-called classical myocardiopathies, but let's look at something which is often used in association with them, because a primary inflammation of the myocardium, whether it's autoimmune or caused by known infectious pathogenic entities, would be considered a myocarditis, would be considered a myocardiopathy as well. What's the definition of myocarditis? Primary inflammation of myocardium. In the case here, we have a little list of known pathogenic causes, and at the bottom we have not known causes, which means they are autoimmune. They may follow a viral infection, but they are often associated with the classical systemic autoimmune diseases like rheumatic fever, lupus, and sometimes with drug hypersensitivities causing the autoimmune sensitization as well, like alpha-methyl-dopa, one of the big hypertensive agents of a couple generations ago. I don't think it's used too much now, as well as the sulfas have also been indicted as primary myocarditis as well. But the thing that's in the biggest letters here is the Coxsackie virus, both A and B. If you were to go to a grand rounds and they presented a case of viral myocarditis, most likely, after they did all the studies, they would probably say it was a Coxsackie B virus. CMV, you know, one of the herpes viruses. HIV have also been known to cause a primary myocardial inflammation. The trypanosomes, especially Chagas disease in Central and South America, they have a high association with myocarditis as well. Even parasites like trichinosis and toxoplasmosis are occasionally noted to cause a direct inflammatory response from the myocardium. Lyme disease, well, it's something that I had a couple of years ago, and when I was reading about it, it seems like most of the cardiac effects of Lyme disease are in this category of chronic Lyme disease rather than acute. Diphtheria, something else you may never see or treat in your life, had also a very high association with a diphtheric Corynebacterium diphtheriae causing a primary bacterial myocarditis as well. So that's generally the concepts of etiology for myocarditis. And remember, Coxsackie B is always at the top of the list. I'm not going to try to fool you into thinking that the histologic pattern of inflammation determines the etiology. I will just say most myocarditis, even if it's an acute myocarditis clinically, it's usually characterized by infiltrates of chronic inflammatory cells or lymphocytes pathologically. So here are myocardial fibers, which you could recognize, and you could see that there are generally a lot of peppering diffusely as well as locally of lymphocytic-looking cells. In this myocarditis here, I think I could convince you that a larger number of these are polys. And of course, here is one in which it looks like we have some giant cells. I am not going to tell you that on the basis of these pictures here, we could guess what the actual cause was, okay? Most of them are simply lymphocytic infiltrates. However, I will tell you that if you have a good number of eosinophils infiltrating the myocardium, that would speak more for a parasitic myocarditis, like trichinosis or toxoplasmosis or Chagas disease, because parasites are associated with eosinophils. Okay, now here's one in which we're lucky enough to see little granules within myocardial fibers. And I can't prove it, but I can tell you this is from a case of trypanosome myocarditis. Okay, this is from a case of Trypanosoma cruzi, Chagas disease. And in this case, you may not see much by way of actual inflammatory cells, but you can identify the small organisms. Okay, I'm going to move on to the one of the last topics in myocarditis. And you have to remember, I have personal experience with adriamycin in general. Somebody that has that qualifies for chemotherapy, especially this is the main drug used with breast cancer, if they do not have enough myocardial function, they might hold off on the adriamycin until they can restore, hopefully, myocardial function, because this is a very, very powerful chemotherapy. It actually helped my wife quite a bit too, but it's also has a bad reputation for being cardiotoxic. So don't give adriamycin to somebody with a bad heart. That's the general rule. The cyclophosphamides were also in that category. There's also something I was reading more about last night, the concept of catecholamine myocarditis or catecholamine cardiac toxicity. Excuse me. People that have pheochromocytomas or have even an extrinsic excess of catecholamines can frequently show myocardial anomalies. And I read a little bit more into the cause of that, and I would say it's probably the classical example of a stress or an exhaustion atrophy. The sustained presence of catecholamines, norepinephrine on a heart can cause it to malfunction, although originally it's intended to make it function better. So it would be probably what we pathologists would describe in day one as an exhaustion type of atrophy. And remember, amyloid is not only associated with aging, in which you could identify some Congo red staining material, which turns green when you polarize it, but also with people that have had plasma cell malignancies and a buildup of immunoproteins. And sometimes the amyloid can be almost primarily limited to the heart. Now, whenever amyloidosis is primarily limited to one organ, like liver or spleen or heart, relatively to one organ, very often that's very likely to be a familial type of amyloidosis. Finally, buildup of iron, of hemosiderin, very easily seen with a Prussian blue stain from hemochromatosis, can also produce a myocarditis, myocardopathy type of picture. And I've once again repeated another common cause, and don't ask me why, but both hyperthyroidism as well as hypothyroidism can produce a myocarditis. Okay, we're done with the heart. Why don't we spend a little bit of time talking about the external covering of the heart, the pericardium. We certainly gave a lot of time to endocardium, so why not say a few words about pericardium? Now, normally there's a few ml of clear serous fluid in your pericardial cavity. Okay, normally your pericardium is not dry. It has about 30 to 50 ml of clear serous fluid. Remember the mesothelial cells, which line both the visceral as well as the parietal or fibrous pericardium? Have two layers, and that first layer secretes a lot of substances which can be called mucopolysaccharides, just like in the joints, for example, that will make the heart a little bit lubricated during its phase and have a nice slippery interface between the visceral and parietal pericardium. If the amount of fluid increases, either because there has been a rupture of the myocardium and leakage of blood into the pericardial sac, or there's been a traumatic perforation. Or, if you remember, when the aorta originates from the heart, I think we'll see a picture of this in lab, a dissection of an aneurysm can also cause bleeding into the pericardium as well, just from the way the aorta is arranged. So these are all common reasons for pericardial effusions. When they cause functional failure of the heart because of that increased amount of fluid and pressure, that's called tamponade. Okay, what about primary inflammations of the pericardium? Here's a case in which the quality or the texture or the appearance of the exudate or fluid is often a sign of what the etiology is. Now, let's take the easy one first. If you see a purulent reaction, pus within the pericardial cavity, think of pus anywhere. Think of pyogenic bacteria. Think of staph. Think of strep. Think of a bacterial pericarditis. If you see that the primary exudate is watery, you could think of two things. You could think of your systemic autoimmune diseases like rheumatic fever, like lupus, like scleroderma, or you could even think of uremia, or you could even think of tumors, technically, although tumors is variable. You could see hemorrhagic exudates with tumors as well. Now, probably the single most common cause overall of a pericarditis is uremia or renal failure, okay? Most of the time, the exudate of uremia is fibrinous, but it can also be serous, so that's why you see uremia in both lists. If you had, for example, radiation to the heart in somebody that had an advanced lung cancer, that could very easily be a fibrinous pericarditis as well. What about somebody that has had open heart surgery and develop a pericarditis after that? Well, that's most likely to be fibrinous. And in the lab, we're going to see a case of a myocardial infarct in which not only is the myocardium inflamed because of the necrotic myocardium, but that extends to the pericardium as well. So a pericarditis following a myocardial infarct is generally termed Dressler's syndrome. And you can hear pericardial rubs on these patients as well. A hemorrhagic pericarditis, think of malignancy or TB. As a matter of fact, when somebody has a hemoptysis, what are the first two things you think of? Malignancy or TB. So when they have hemorrhage in the pericardium, think of those same two things at the top of the list. Finally, the easy one is if you had a caseous or granulomatous pericarditis, it's probably TB until proven otherwise. Now, another concept to remember is that a lot of these changes that we see here are fairly acute, like purulent, like fibrinous. These are all part of an acute inflammatory picture, okay? Now, the more chronic a pericarditis becomes, the more deposition there is of collagen and fibroblasts, the more likely that pericarditis will become constrictive. So a good conceptual question would be, what would be more likely to cause a tamponade or a constrictive pericarditis? Would it be an acute inflammatory pericarditis, or would it be a chronic one? Okay, and guess what? You got my answer right. Now, I notice that there's a bunch of questions there, and I haven't answered them. So I'm probably guessing that Dr. August has been answering them, and I'm really, really grateful for that. Now I don't have to worry and try to fragment my focused attention when I see the little chat box sliding around while I'm trying to focus in on a topic. Here's a classical pericarditis. Okay, what color would you call this? I'd call that red. What color would you call this? I'd call it kind of a whitish yellow. But in both cases, the substance which is coating the surface of this visceral pericardium and this is fibrin. So this is a fibrinous pericarditis, and I have never ever seen a pathology book in my life in which the term fibrinous pericarditis, and remember we said this is your definition or differential of fibrinous, MIs, uremias, radiation, open heart surgery. I've never seen a case in which fibrinous pericarditis has not been called bread and butter pericarditis. So I didn't want to break the tradition here, and a bread and butter pericarditis is called fibrinous just from the fact that when you peel back the parietal pericardium, the fibrous sac here from the visceral pericardium, it looks like you're opening up a butter sandwich and you got butter sticking to one of the sides of the bread. Okay, I want to mention this as well before we get into the short topic of cardiac tumors. I'll make it in form of a question rather than a statement. If you had a primary tumor of the pericardium, either visceral or parietal, what do you think that tumor would be called? That's the question. Aha, no answers yet. Well, it might result, somebody got it right. Mesothelioma, think about it. The mesothelial cells line pleura, they line peritoneum, and they line pericardium. So primary tumors of the mesothelium lining these surfaces are mesotheliomas. But I'm just mentioning that as something that's really rare, and quite frankly, I've never seen it, but it would just be a concept worth repeating. What I'll now talk about are the real non-mesothelioma pericardial tumors, but the primary heart tumors. It's probably very hard to understand why a heart could get a tumor, simply because you all know that cardiac muscle cells do not divide, okay? They do not undergo mitosis. They're like neurons. They don't even have a spindle apparatus, okay? So how could something form a tumor that does from cells that don't divide? Well, let's answer that question by saying that without a doubt, 90 or so percent of the tumors of the heart are not direct tumors of mature cardiac muscle fibers. They are tumors of other portions of the connective tissue. For example, fibroma. You have fibrous tissue in the heart, so you can have a fibroma. Probably the second most common type of tumor of the heart after a myxoma is a lipoma. Why? Because you have an abundant amount of subpericardial fat. You can also have tumors of the heart valves of the connective tissue, and they're called fibroelastomas. I'm going to show you a little picture. Oh, I can't. Oh, darn it. It won't let me edit this thing. But if you could notice, if you zoom in your eyeballs here, this is almost like a papillary type of tumor. So a papillary tumor of a heart valve is a connective tissue is most likely going to be a fibroelastoma. Okay? You can have a tumor of the heart muscle cells, but they are not going to be derived from the mature heart muscle cells. They will be derived from the precursors. So yes, there is such a thing as a rhabdomyoma and a rhabdomyosarcoma, and technically they could be derived from the same cells that give rise to the myocytes as well, but they're not going to look like myocytes. They're not going to have striations. They'll just look like primitive cells. I've been skirting around the issue very often. I've been talking about the rare tumors. For example, I've never seen a rhabdomyosarcoma of the heart. I've only seen a couple of rhabdomyomas, and they're mostly in kids. But the most common tumor of the heart is something called a myxoma. And specifically, they're predominantly in the left atrium. And I'm going to show you a myxoma. Here's a left atrium that's opened up. You can see something here that looks sort of like a mural thrombus or a blood clot. And when you cut through it, it has this myxoid, mucoid ground substance, perhaps some blood vessels, perhaps some fibroblasts, perhaps a sprinkling of inflammatory cells, macrophages, perhaps. And good, somebody just asked a question, why the left atrium? You want to know something? That's a really, really good question, and I'm gonna give you a good theory here. I'll answer the question why left by asking you another question. What is the most likely chamber of the heart to get a mural thrombus? It's also a left atrium, isn't it? So when you study the myxomas, it's very possible that a large number of them, or perhaps most of them, are not really true clonal neoplasms. They may very well be likely just myxoid change or degenerative myxoid change within a mural thrombus. So if somebody tells you that myxoma is really not a true word, it's not a true neoplasm, that most of these are probably just degenerative or myxoid changes in mural thrombi, they're probably right. Now, whether they can be proven to be a true clonal neoplasm or whether they're just degenerated mural thrombi, to tell you the truth, I really don't care. But they present as tumors, don't they? In this case, the tumor looks like it's very well fixed to the left atrial wall. It doesn't infiltrate it, it's just adherent to it, just like a mural thrombus. Okay, what about non-cardiac tumors that have effect on the heart? Let's think of some logical things. For example, could you have metastases to the heart and or pericardium? Of course you can. You have metastases to the heart from anywhere. But what do you think the two most likely sources would be? When you look at a large series of pericardial and myocardial metastases, almost all of them are coming from either the lung or the breast, possibly because of the proximity. Probably the number one tumor to metastasize to the pericardium would be the same tumor that it's in direct anatomic proximity to it, and that's the lungs. I think breast is probably in second place. What about if you have a tumor like a lymphoma or a heart or a lung cancer that obstructs one of the large vesicles like the pulmonary artery or the aorta? That would be considered a direct consequence of a tumor. What about tumor emboli? What about tumors that not only metastasize into the veins, but extensively involve emboli into the lungs? Those would be another example of a direct anatomic consequence of a tumor. What about some indirect causes? Remember, we talked about a type of endocarditis seen with adenocarcinomas of the GI tract and pancreas. We call those trousseaus. We called them a migratory thrombophlebitis, a non-bacterial endocarditis. Well, that would be another example of something disrupting the endocardium from a tumor that causes a direct effect on the endothelium of the heart, endocardium. We talked about carcinoid having a disastrous effect on the endocardial surface of the heart, both atria and ventricle, and especially right-sided, simply because of the fact that the concentration of serotonin is greater in right-sided blood rather than left-sided blood because the lung degrades it. We also talked about pheochromocytomas, a tumor of the adrenal glands, is having a bad effect on the function of the heart due to excessive catecholamines. And if you think about it, multiple myelomas producing massive amounts of immunoproteins, gamma globulins, monoclonal proteins, resulting in chronically buildup of immune protein. Amyloid A would also be an example of a malignancy that's non-cardiac or myeloma affecting the heart, just like the pheochromocytoma is non-cardiac, just like the carcinoid is non-cardiac, just like the migratory thrombophlebitis of an adenocarcinoma of the GI tract or pancreas is non-cardiac, just like these are non-cardiac. Finally, we also mentioned that chemotherapy itself, especially cyclophosphamide, adriamycin, can have a very toxic effect on the myocardium as well. And it's worth repeating, if your radiation field has to include the heart with some of the extensive lung carcinomas, that may also result in a bad effect on cardiac function as well. I think I have a couple more slides. We'll say a couple words about transplants here and maybe take an early break. Transplantation is a most spectacular event. It can massively save lives. There's probably 1,000,000 times more people waiting for it than there are hearts that can be transplanted. It has to be a very, very selective process. The hard facts are, however, is that the 5-year survival of a transplant is about 60%. Now, you can select the recipients age-wise and so forth, so maybe you could pump this number up a little bit, but the hardcore facts are people that did cardiac transplants also get diseases of their transplants. And it is very, very, very easy to understand that if this myocardium that you see here, these myocardial fibers, are not inherent to the recipient's protoplasm, that it would be always a possibility that eventually you would have a host versus graft reaction, not graft versus host like a bone marrow transplant, but host versus graft, where the patient cells are fighting it. There are many, many ways to ensure the likelihood that it won't be much of a battle, but after all is said and done, the reason why only 60% while the 5-year survival is only 60%, is because the patient's T cells are reacting against these foreign substances. I think we're through with the discussion on heart. We're 130 PowerPoints. We did it in 3 days. We're going to have a nice lab. And I see a lot of questions here. I'm going to put the window down over here. I see that there have been a lot of questions, but I do not see Dr. August's responses. It's possible I cannot see her responses. It's possible I can only see your questions. So I'm going to ask the question because I see a whole string of questions here. Was Dr. August able to respond to a lot of your questions? Because this is the first time she's doing it. I want to make sure that she knows how. Okay, good. I'm seeing that people have said that she has responded. Unfortunately, I have not been able to see her responses. I can't even see my own responses as well. So I'm very, very glad Dr. Deborah August is with us, and I hope that she likes us as much as we like her, and I hope she stays with us. In fact, I've even encouraged her to someday bring a microphone, plug it into her PC, and chat with us a little bit. So we're done with heart. Let's look at the clock. It's already 1 hour. So here's what we'll do. We'll take our 10-minute music break. I want you to go during the 10-minute break and get your Radio Shack microphones out of your drawer, or maybe you have a laptop where the microphone is built in. We'll do a lab, and then after the lab, maybe we can all do a verbal chat. And if nobody wants to do a verbal chat, then I'll probably do something I don't really want to do, and that's to start a brand new topic of red blood cells. So here are our 3 songs from Regi Mohammed, and we'll be playing them during the break, and we will see you in 10 minutes.
لما الحنين بياخدنا لمرجحة بتحضننا وبتعلى فوق سور بيتنا تاخدنا لفوق وبتسعنا نلاقي الطفل جوانا عينيه بالفرحة مليانة وضحكة مش مفرقانا في بشرة خير لأيامنا لما الحنين بياخدنا لمرجحة بتحضننا يا ريت ترجع ليالينا تاخد تاني أيادينا تجمعنا تخلينا نشوف من تاني قدامنا لما السنين بتعدي وتسرق منا أحلامنا ترجع حلم قلبي بريء تقول غنوات بالريق وترجع بيها أحلامنا لما السنين بتعدي وتسرق منا أحلامنا دي بتجري ما تهدي تضيع ملامحنا وكلامنا تتركي ايدينك ايدي تنسى من عايش عشانك ان كان ميت ولا حي يا ريت الله علي تتركي ايدينك ايدي تنسى من عايش عشانك ان كان ميت ولا حي ولا نويت تعشق تحب ثاني أمانة لا تنساني إني أحبك الله إذا نويت تعشق تحبني أمانة لا تنساني إني أحبك الله طمني عليك إذا حسيت بأيها بتلقاني مع قلبك إذا بكى منو يحس فينا لا إذا دقت العناء منو يداري قلبي في يوم إذا شكا يعني بشوفك بعد ولا اسمع صوتك أبد وإذا ضاقت علي دنياك من غيرك أي أحد يعني بشوفك بعد ولا اسمع صوتك أبد وإذا ضاقت علي دنياك من غيرك أي أحد وإذا نويت تعشق تحبني أمانة لا تنساني إني أحبك الله وإذا نويت تعشق تحبني أمانة لا تنساني إني أحبك الله تذكر هالمكان أنا وأنت زمان تذكر يا بتسكيني حب وحنان إذا ناوي الغنى أبرضى بالعذاب أبرضى أنا في قلبي ألم وحزان خلص محرمات وبخليك أنا بهواك وإذا خايف أنا أنسى روحي ما أنسى خلاص محرمات وبخليك أنا بهواك وإذا خايف أنا أنسى روحي ما أنسى وإذا نويت تعشق تحبني أمانة لا تنساني إني أحبك الله وإذا نويت تعشق تحبني أمانة لا تنساني إني أحبك الله ودي يمر اسبوع من غير زعل ودموع ونعيش مثل الناس اهدى شعور واحساس احبابك كنا اثنين قلب وانقسم نصين الله يا الدنيا شوفوا وصلنا وين ودي يمر اسبوع من غير شعور واحساس احبابك كنا اثنين قلب وانقسم نصين الله يا الدنيا شوفوا وصلنا وين احسب معايش بقى في شي ما عشناه غيرة وهم وشقاء ودوخة وضيقة وحرام علينا نهدم بدينا حب احنا عشنا معاه حرام علينا نهدم بدينا حب احنا عشنا معاه كافي عذاب كافي جراح أما نعيش في كل وضوح ولا خلاص كل انفداء بيروح كافي عذاب كافي جروح أما نعيش في كل وضوح ولا خلاص كل انفداء بيروح من كل ما نتأثر أي غلطة انحاني وما في أحد قادر يتحمل الثاني ضاعت مشاعرنا وزادت مشاكلنا واللي يزعلنا وين المحبة وين
Wow, that was really, really great music. I'm not used to Arabian music, but that certainly seemed powerful. I didn't understand a word of it, but I really liked it. Thank you, Regi Mohammed, for the music. And I also want to thank Dr. August for helping us as well. I was able to chat with her a little bit during the break. Apparently she's at work and she has her headset on, so she's doing all of this possibly while she's doing a regular day's work, maybe even reading some slides. I hope that the questions were stimulating and that you will continue to join us as well. We'll do everything we can to make it worth your while, except to give you a lot of money. You know, one of the thoughts that I had during the break was way back before most of you were born in the 60s and 70s, we had a big theater here in Chicago called the Kinetic Playground. And it's where all the acid, hippie music occurred and all the flower children. And there used to be tremendous psychedelic displays of color like flowers. So when I was watching this beautiful display of, I think the search word was neon flowers. It reminded me a lot as when I used to go with my wife to the Kinetic Playground. Okay, well, I promised you, I threatened you that we would have heart lab after we did our heart lecture. And a very good place to start heart lab is right here. You see this little square or rectangular room here? This is your lab. So get up off of your chairs in the auditorium and here, walk down the hall with the arrow. Okay, now here's your lockers right over here. You could put on your lab coats, and then you could keep on walking down the hall over here. And then finally, when you get to the end of the hall, you start to smell some formalin. So you open the door, and now the formaldehyde is overpowering. Now you're in the lab. You have your specimens here. You have your microscopes. You have your slides. And you're looking at your first slide. I guess it's called AMYL, so you probably don't have any idea what that slide is going to be. But let's put it under the microscope and call over the pathologist to have them look at it with you. And I've also mentioned to Dr. August, who does have a microphone, but she might not be able to talk, that if she wants to join us in the discussion of some of these slides. She hasn't seen them before, so it would be a little bit unfair, but these are all classic second-year medical student teaching slides, and it'll be on topics that we talked about. So here we have 1, 2, 3, 4, 5, 6, 7. There's 10 slides during our lab, and we might as well start with the first one. And alphabetically, it's AMYL. So I think you probably have an idea of what this might be, but just forget about the labeling on the slide, and let's try to be objective here. And we're looking at a big red piece of tissue, and you can see some of this tissue is separated by either looser connective tissue. You know, there's a big artery over there. You know that some of these fibers, or whatever they are, seem to be separated by a little bit of connective tissue, or maybe even artifact cracks. And I'm sure as soon as we zoom in a little bit now on medium power, we'll probably be able to figure out what kind of histology this is. Well, it looks like it's heart. You could see that these are fibers. You could see that the nucleus is in the center of the fiber. You don't see any striations on here because in this field most of them are cut axially. Perhaps if we looked on high power, some of these fibers that look like they're a little bit more longitudinally cut might show us some striations. But as we move around this piece of tissue, we've already noticed that there is an area here that looks hyalinized. It doesn't look like it has fibers. Perhaps there are smaller areas like here that might look hyalinized too. And just to say we're being fair, what I'm going to do is I'm just going to take another random section here. And I'll tell you what, why doesn't somebody name any state of the United States right now? Go on. Okay, Texas. Texas is down here. So let's go to Texas. And once again, you can see fibers again, but you see these little pools or areas in which the fibers are disrupted by these hyalinized, eosinophilic, relatively acellular areas. Now, you all know technically the differential diagnosis of hyaline. It means some kinds of protein substance. Could it be fibrous tissue? Could it be fibrin? Could it be some collection of protein due to an enzyme deficiency and a protein buildup? Or could it be amyloid? Well, it could be any of these things, but let's say that you did trichrome stain and this area here did not turn green. Let's say that you did a Congo red stain and this pinkish area here was now really red. Would that make you think it's probably amyloid? And furthermore, let's say you now polarized your filter in which you're looking at the red Congo red stain, and you see that there are nice green areas in here. Now you have a red stain that's now green with birefringence. Well, let me tell you, you no longer have to suspect it's amyloid. Now you know it's amyloid. Of course, there are ways of looking at it with electron microscopy as well, because amyloid fibrils have a certain appearance if you really zoom in on them. So, what would you want to diagnose this case as? How about amyloid myocardiopathy? Or would you like to call it amyloid myocarditis as well? I'm not too sure if I would be too thrilled with the itis aspect because there's not much here by way of inflammation. This is a heart that is loaded with amyloid. Let's say that the liver didn't have amyloid, the spleen didn't have amyloid, the pancreas didn't have amyloid, only the heart had amyloid. Would you think this might be a familial type of situation? Yes, most isolated organs, amyloidoses, are familial. What else can we say? Would you want to call this perhaps a restrictive cardiomyopathy if this buildup of all of this substance interfered with proper relaxation or diastole of the myocardium? Yeah, you could probably call it restrictive, probably. It's really, if this heart was so loaded with amyloid that it was lost its normal relaxational compliance, then you would call it a restrictive cardiomyopathy. Would you also like to perhaps use the word infiltrative myocardiopathy because this amyloid seems to infiltrate? Yeah, you probably could, although we did not talk about infiltrative as a separate functional entity to itself. It's basically just an adjective. Here, let's get rid of this slide. Let's look at the big picture again. You know, I looked at this last night, and I bet you, hold on, do some of you remember what I told you a long time ago, is that when amyloid starts in a certain organ or anywhere in the body, where does it usually start? In other words, if this heart, 10 or 20 years ago, had just a little bit of amyloid that you could see, which part of the heart? Yeah, around blood vessels. That's why when you do a biopsy for amyloid, very often you could just biopsy some of the blood vessels in an abdominal fat pad. I think I could convince you that some of this wall of this vessel does not have a normal cellular smooth muscle configuration, but it's kind of hyalinized, just like the amyloid that you see here. Okay, but final question, just to make sure we're on the same wavelength here, folks. Let's say that your mind was a computer and you counted all of the pixels in this matrix here that had amyloid versus the pixels that had either normal tissue or normal heart blood. What percentage of this myocardium in this field quantitatively is amyloid? I saw a 50, I saw a 40. I would have probably said about a 35 myself, but everybody is saying less than 50. If somebody thinks it's more than 50, maybe they're right if you actually look at some of these little subtle areas here. By the way, if we stained this with trichrome, would it be green? This area down here? Yes or no? It would not be green because it's not collagen, it's amyloid. But what if we stained this pink area down here with trichrome? Then it would be greenish blue, wouldn't it? Okay, we're done. Let's move on to the next slide. This one, it's called amipamin. I don't know what that means, but don't be prejudiced by it. We once again have pink fibers. I think you could see that in part of these pink fibers, whatever they are, you can see that it looks like there's a band of perhaps infiltrating cells. And you could see them around here. It almost looks like it's kind of like infiltrating around a certain region. Somebody's already given me the answer. I'm mad. I wanted to try to lead them into it. But let's take a look at the area that does not look like it has these irregular infiltrates. Let's take an area like down here, perhaps in Arizona. And could I convince you, folks, that this is probably relatively normal myocardium? Yes or no? Oh, yes, I know, but some of you are going to say, well, what about these big blocky nuclei here? Couldn't this be some myocardial hypertrophy? Well, yeah, it could be, but I'll admit it probably are somewhat hypertrophic fibers, but I won't go any further than that. Now, can I ask you another question? Do you see way here in the southwest? Do you think that's the endocardial surface of the myocardium, or do you think that's the pericardial surface? It's pericardial because you see fat. You don't see fat in the endocardium. So let's kind of move that up a little bit. And sure enough, you got some vessels running in here, but it's not the exact surface because you still have more myocardium. And I'm even wondering, here we go. Now we got a nice big sub-epicardial or sub-pericardial fat pad. There's a little artery there. But I know you're not interested in the normal stuff. I know you want me to zoom in over here where you see these abnormal infiltrates. So let's do that. Let's go to Oregon over here. Make a nice little state of Oregon. And I think where you see myocardial fibers here, we are now noticing that at the edge of them, there are infiltrates of cells. And guess what? I'm going to take another little picture here where you have relatively uninfiltrated on the right, and in most of the west, you have infiltrates. What kind of cells are infiltrating? I'll give you two choices, polys or monos. Yeah, they're all polys. Everybody knows that. And by the way, is there something that you also notice? Do you notice that where there is a heavy infiltrate of polymorphonuclear leukocytes, polys, PMNs, granulocytes, do you notice that in most of the fibers, the nucleus is absent? Do you see how it's very difficult to find myocardial fibers that have nuclei within the infiltrated area? But what about the area here that is not infiltrated? Most of those have nuclei, don't they? Some of them may look a little bit blocky, nuclei, but they mostly have nuclei, don't they? So that tells you that by the time polymorphonuclear leukocytes invade dead myocardium, chances are the nucleus has already dissolved, or karyolysis. In fact, karyolysis usually precedes neutrophil infiltrates by about a day. So it's very possible that if this man had lived, that the next day these nuclei might be gone. This is an acute myocardial infarction. And by the way, somebody did become the devil's advocate, and they did say, well, is this a myocarditis? Well, here, let me ask you the question. Because you have inflammatory cells infiltrating myocardial fibers, even if they're dead myocardial fibers, technically speaking, could you call that a myocarditis? Absolutely. That's the pathologic concept. Most people would just call this an infarct with secondary dead muscle and neutrophil reaction to it. But you could call it a myocarditis. But remember, most of the myocardiopathies, myocarditis, are diffuse processes, whereas a localized myocarditis is probably going to wind up being a myocardial infarct. Do we want to zoom back out and look at any other part of this? I don't know. Let's zoom out a couple of notches. Oh, well, let's look at one of the arteries if we can. Maybe we could probably figure out why this thing could be infarcted. Let's go to Michigan or over here, or maybe you want to call it Ohio or something. Well, this is a small artery. and it does not look like it's thrombosed, so it looks relatively normal. So if this infarct was caused by a thrombosis of a major or even not a major artery, this artery here does not look like it's where the thrombus is. In fact, it doesn't even look very atherosclerotic at all, does it? Okay, final question. I've said it before, but I'll say it again. Do you see how square and blocky that nucleus is over there? What does that mean? It means that before this guy even had his infarct, he probably had some type of myocardial dysfunction in which certain fibers were becoming hypertrophic, perhaps as a response to try to make up for other reasons for myocardial loss of function. My God, I can't believe I said that in one sentence. Okay, we'll call this a day. We'll call this acute myocardial infarct. Last question. In a classical infarct, in other words, I just got a clot in my heart this very second. How much time will it be before neutrophils infiltrate the dead myocardial fibers? I'll give you three choices. We'll say 1 hour, 1 day, or 1 week. Those are the choices. Yep, you're all saying about 1 day. So it could be as early as 12 hours. It's usually not much more technically than about a day or so. Good. Most of you got that right. Let's move on to the next slide. And I don't know what we named this, but I don't even want to look at the labels anymore because I don't want to prejudice you. Well, we can see that there's a lot of fat here, and we can see that there's a lot of muscle here, and I'm guessing it's not smooth muscle, and I'm guessing it's not striated muscle. It looks like it's cardiac muscle because the nuclei are in the center, and maybe if I go on higher power, maybe I could find you some striations too. What the hell, let's do that. Yeah, I think when you see, no, you can't look at these perfectly linear lines. Those are digital artifacts. I think you could say that, in all honesty, this is pretty good cardiac muscle. But I'm going to go out now, and I'm going to show you that if you see fat at the edge of cardiac muscle, you're probably on the pericardial side. So you got pericardium, perhaps all over here, okay? But now you have an area of the myocardium in which you see an extension of some type of fibrous tissue. Even though this is pericardium here, when you see this extension of fibrous tissue, you're thinking, could this be a valve leaflet? So you just went from pericardium to endocardium in practically a few cells difference. You're at the base of the aorta right here. I guess it could be the pulmonary artery, but it's most likely the aorta. Most of the left-sided valves have most of the diseases. And you can see that the valve is thickened. You can see there's a lot of red material on it. And furthermore, you can see a lot of nests of blue granular stuff. Now, let's be scientific about this. Let's make a little box here. And if we call this a heart valve, then you know that these cells here have to be endothelial cells, right? Right along the edge. And perhaps these cells are also endothelial cells as well. And we're going to move into the thickened area now. And we'll look, all of a sudden, your heart valve is really, really, really thick. And you can see some very fiery red eosinophilic substance here, and here, and here. And you can see acute inflammatory cells. So that means that this red stuff is probably fibrin, right? And not only are there a lot of neutrophils infiltrating this valve, and there's a lot of fibrin, which is classical for fibrin. Now, I know what you're thinking. You're thinking, well, why couldn't this be fibrous tissue or amyloid or something? It could be technically because it's hyalinized. But what type of hyalinized material do you expect to see in association with acute inflammatory exudate? That's fibrin. So if this is fibrin, which is an acute inflammatory product, and now you got these little dark granular nests within the acute inflammatory process and within the fibrin, you're thinking, well, this is probably not calcium, is it? Because calcium is associated generally with chronic changes, fibrosis perhaps. Now you got these little blue nests inside of fibrin. And I'm going to ask you a question here. I'm going to blow up this area. You're going to see all the neutrophils here. You know those are neutrophils. You know that one of the products of acute inflammatory exudate, perhaps the main product, is fibrin. But you also have these dark, dark, dark blue nests of granular things. Can I ask you a question? What do you think this blue stuff is, if it's not calcium? Yeah, gram-positive bacteria. Isn't that awesome? So usually when you see dark blue granular junk, you normally say, oh, that's just calcium, and you don't even blink your eyes. But when you see it in association with an acute inflammatory process, you know that you could probably culture this stuff and grow out either staph or strep, right? Because it's pyogenic, and gram-positive bacteria are also blue and hematoxylin. And let me ask you another question. We said the most likely stuff that is in this blue area is staph or strep. Here's a question. What if this person was a drug user? What would it most likely be? Staph or strep? An intravenous drug user. Staph, that's right. What if it's a person that went to the dentist who didn't use drugs and they got a severe fever and endocarditis, several days after a tooth extraction? Then it would probably be strep viridans as well. Isn't this great? This is a classical vegetation. And these are the things that shower off to become either Osler's nodes or splinter hemorrhages or Roth spots in the eye. And this is a classic vegetation. And I'm going to just go back again and just show you how beautiful this is. It's also a really good example is you always think of endocardium as being far away from pericardium, but in this case you have this endocardial structure here called a heart valve being very, very close proximity to pericardium because this is the base of the aorta. Okay. I really like this. Somebody said, where is pus? Well, that's a good question. Probably pus is basically a gross word. It's not a microscopic word. But technically speaking, if you took all of these neutrophils here, which are practically just microscopic, and you put them inside of a big bag, it would look exactly like pus, because pus is nothing more than neutrophils and fibrin. Okay, we're done with this case. Here's another slide. It looks not quite as red as some of our other slides, but you can see one surface is pretty smooth, the other one is kind of irregular and jagged. So even though there's no fat here, you would probably think if this was myocardium, this would probably be the pericardial side, and these would probably be the muscular endocardial side, perhaps the beginnings of some papillary muscles even. Now, the question I want to ask you about this slide before we go into high power is, do some areas of this tissue look a little bit bluer than others? For example, you see this area here? Does that seem a little bit pinker than, for example, this area here? What would cause pink tissue to become more blue? Perhaps infiltration of lymphocytes might be a reason. So let's get away from all this theorizing and actually take a nice section here through Utah or maybe New Mexico. And I think I could convince you that when you look into this area here of myocardium, it looks like there's infiltrates of cells. And if you don't believe me, let's go higher on our microscope to high power. So let's keep this very, very, very simple. Here you have a myocardium in which you could see generally diffuse, but in certain areas even more dense infiltrates of inflammatory cells. And you want to go a step further? Do you want to guess if they're neutrophils or lymphocytes? Go on, give it a guess. Neutrophils or lymphocytes? Yeah, most of you are saying lymphocytes. In fact, all of you. Some are saying chronic. So there's a lot of cells here, but let's take a random area. Let's take another area, for example. Let's take, an area that even looks pinker, for example. And I'm going to ask you the same question. Do you think that this is a lot more cellular than what you should get with normal myocardium? So we have a diffuse infiltrate of chronic or lymphocytic looking cells throughout most of the areas of the myocardium, and in some areas it's a little bit worse than others. What is your diagnosis? Myocarditis. Now, two people came up with intelligent answers, and I'm going to discuss those. One person said lymphoma. For example, could this be a lymphomatous, a well-differentiated lymphomatous infiltrate into myocardium, technically speaking, on a histopathologic basis? Although, yes, it could be. What if this patient had very strong antibodies against Coxsackie B virus? And no evidence for a primary lymphoma anywhere else? Then you just call it viral myocarditis. Now, another person said chronic myocarditis. Well, technically, that's a good answer too. But remember, even though the cells that are infiltrating the myocardium here are what we call chronic or lymphocytic or mononuclear like inflammatory cells, clinically, this person may be diagnosed as acute myocarditis. Because in most of the acute viral myocarditises, the primary cell, even in the acute phase, is the lymphocyte. Remember, we kind of said a long time ago that a lot of the viral infections are characterized more by perhaps lymphocytic reactions, whereas the pyogenic bacteria, many bacteria, would be more likely to evoke neutrophils. Okay, everybody got this one right, and now you know why this particular slide was labeled COX-B. Now, could this be any viral myocarditis? That's the question. Okay, yeah, it could. Could it be some type of parasite? Could it be diphtheria? Could it be, for example, trypanosomes? Yeah, I guess it could be. If it was parasitic, do you think you might possibly see more eosinophils in the infiltrate rather than lymphocytes? Yeah. And also remember, we even saw a case, which we don't see in lab, but we saw a case in the lecture of where you could actually identify the trypanosomes. Remember, trypanosomes have a very, very strong predilection for myocardium. Okay, let's go to the next slide here. Slide number 5 of 10. Okay, well, it's pink. You could see that there's fat on this side. Oh, it also looks like the visceral pericardium may also have a few inflammatory cells around it. Let's take a look. Yeah, so it's sort of the subepicardial fat, but wouldn't you agree that technically you got some chronic inflammatory cell infiltrates here in the pericardium as well? So pathologically speaking, you could probably call that a chronic pericarditis. But I don't think that, to me, looks like it's his primary problem. Now you're getting into the myocardium, which up here does not look too bad. Maybe there's a little area of fibrosis there. I don't know. Let's see if we could see some striations, which means we'll have to look at an area where the fibers look more longitudinal. Maybe we'll see striations. Yeah, I think I could probably convince you. Do you see the striations along here, by the way? Do you see the striations along here? Oh, do you see these striations? Yeah, so you know this is striated muscle in which nuclei are in the center of the fiber. By definition, that's cardiac muscle. And this doesn't look too bad, does it? So now that we've identified this as fairly normal cardiac muscle, and there's a little bit of chronic pericarditis around it, let's move the slide. You see muscle, muscle. You know, that's a pretty good size artery there. In fact, you know, you might even, at one time, might have even had to have known the name of it. It's so big. Here it is perforating into the myocardium. Oh, look at it. It looks like there's some subtle areas of fibrosis in this heart. Maybe this guy had an old myocardial infarct. What do you think? Oh, here's a medium-sized artery cut on cross-section. I don't know. Do you want to theorize that maybe that could have been a thrombus? I don't know. Let's take a look. I don't know. It's hard to say. The wall of the artery looks pretty good. I'm concerned with some of these cells in here, but let's not jump to conclusions. You will agree, however, that this area down here looks like it is fibrosis. So does anybody want to guess or theorize that this is perhaps an infarct that is either acute, which means hours or days, or organizing, which means days to weeks, or because of the fibrous tissue, old, perhaps months to years? Yeah, everybody's saying old. So now we'll go and look some more at the muscle. Kind of boring, isn't it? And now we're going to look at some more muscle. And now we're going to look at some more muscle. And look, it looks like along the endocardium here, the muscle is now gone, and instead you see something that's red, and it looks like it might be adherent partly to the endocardium, but it's not muscle. It's fibroblasts, it's blood cells, it's blood vessels. It looks like a big blood clot, doesn't it? It looks like a thrombus that's adherent to the endocardial surface. Now, because this thrombus is adhering to the wall or the internal wall of this vessel, what kind of thrombus is it? It's a mural thrombus, isn't it? Is mural thrombus a common complication of a myocardial infarct? Yes. Could it last for years? That's the next question. Could it shower emboli downstream into the systemic circulation? Yes. And the final question is, if this mural thrombus became degenerated and wound up having a lot of ground substance in it that looked sort of bluish or myxoid, do you think that somebody might call this a myxoma even? You probably would. Remember, I told you the differentiation is not easy to make all the time. So all we have here is a big boring blood clot. You can see blood cells, maybe some fibrin, a lot of fibroblasts, a lot of blood vessels. This is not a recent thing. This is perhaps weeks to even maybe years, probably not years, but it may be weeks to months old. So here you are in court, and this patient's family is suing somebody for $1 million, and the lawyer asks you, "Doctor, that big clot that you saw in the heart, did that happen one day after his heart attack, or do you think it happened weeks or months after his heart attack?" Yeah, it's old. It's weeks or months. Okay, so we have a mural thrombus. Let's take one big last picture at it, and then we'll move on to another case. At first hand, you might think it's myocardium, but look, there's the myocardium, there's the thrombus. Okay, now do you remember I told you that whenever you see something blue and dark and crackly, and it's associated with chronic disease, it's most likely calcium? Look at, there's calcium, calcium. But the honest question is, oh no, this is not calcium. These are just lymphocytes, aren't they? At first I thought they were calcium, but they're not. They're just inflammatory cells. I bet I could find you some calcium, though. Remember, if there's a lot of calcium in this, then you're talking about something that's really old, perhaps months to years. I don't know if this is calcium or if these are cells, but we're about to find out. I think, at first I thought it was calcium, but it looks like it's cells. Yeah, they're lymphocytes, aren't they? Okay, so no calcium here. But if there was a lot of calcium in this mural thrombus, would it make you think that it's like really old? Not just weeks or months, but perhaps months or years? Sure. Okay, we're done with this case. Now, Deborah, I'm not too sure if you're still listening, but you could tell that most of the responses you see now are from students answering questions rather than asking questions. So if you do have your microphone and you want to join in, because, you know, if I'm here all alone talking about this, they're going to think everything I say is true. So maybe I need a smarter pathologist like you to tell these kids that there's always differences of opinion. Okay, next case. We put our slide under the microscope. Oh, we could see what looks like myocardium. We could see a big, big, thick coronary artery running in the this is so big, I'm sure you have to know the name of it. Could this be a LAD or a marginal? Who knows? But you do see that the myocardium here, or at least in certain areas, looks like there might be some infiltrates, not diffuse infiltrates like a myocarditis, but looks like focal infiltrates, like almost like little granulomas. And here too, in the pericardium, you have these little focal infiltrates. In the myocardium, you have these little focal infiltrates. And look, you're down here at the endocardial surface. You see that? You also have a focal inflammatory infiltrate, almost like little granulomas. In other words, this is a pancarditis. Pericardium up here, myocardium down here, and endocardium down here. Now let's take a look at all of these infiltrates and try to describe them as honestly as we can. It's not the artery that's involved, but it's in the pericardial tissue underneath the artery. They almost look like little granulomas, don't they? If you call this a granuloma, I would probably not penalize you, because look, you have focal collections of inflammatory cells, you have multinucleated giant cells. So if you want to call this a pangranulomatous carditis, you could. But what do you think the real diagnosis is? Yeah, these are Aschoff bodies. This is rheumatic fever. This is the pancarditis of rheumatic fever. Sometimes when you see large cells with big nuclei, those cells had a certain name. They were called Anichkov myocytes, but they really wound up to be of a macrophage origin rather than muscle origin. They're all, but otherwise you could probably just call them giant cells. And by the way, what is this thing over here that the granuloma is surrounding? What is this? Come on, you all know what it is. This is a little nerve. Can you tell? This is probably one of those little sympathetic, maybe parasympathetic nerves. Okay, so we found an ash-off body here in the pericardium. Very good. Let's now go to the myocardium down here. And maybe I could convince you that there's some ash-off bodies down here. Probably, look, is that a multinucleated giant cell? Is that a multinucleated giant cell? Is that a sort of a focal collection of inflammatory cells? Here, if you don't believe this is a multinucleated giant cell, let's blow it up some more. Absolutely. So do you think a good definition for ash-off bodies might be granulomas of acute rheumatic fever? Yeah, but they're still called ash-off bodies. Finally, let's look at the one that's down here, clearly along the endocardial aspect. I'm going to blow up the very southwest tip of this slide and hope that it's not too much blown up. Sure enough, you have what look like giant cells and localized inflammations. Isn't that interesting? So we now have a really good demonstration of a true pancarditis. And somebody said non-caseating. That's absolutely correct. You don't have much necrosis or large caseations of coagulation necrosis inside these granulomas. Okay, great. This was really a great slide, and it demonstrates everything we've been telling you about rheumatic fever. Now, here's the last question. Even though acute rheumatic fever is pancarditis, pericardium, myocardium, endocardium, what are the long-term pathologic effects of rheumatic fever? Pericardium, myocardium, or endocardium? Endocardium, it's a heart valve disease. It's the #1 cause of damaged heart valves worldwide, especially in underdeveloped countries. Okay, we'll get rid of that one. Let's take a look at this. Oh, guess what? We're over the limit, but we'll still show you something real quick. Do you remember the last myocardial infarct we saw? It was basically neutrophils infiltrating myocardial fibers. Now, we have myocardial fibers, and the cells which are infiltrating them do not look like neutrophils. They do not look like fibroblasts, but they look relatively foamy. If you see a foamy cell with a lot of foam in the cytoplasm, is that cell likely to be a fibroblast, a neutrophil, a lymphocyte, or a macrophage? Yeah. So this is also a myocardial infarct, but now you have macrophages rather than neutrophils. So what comes first, the neutrophils or the macrophages? Okay, after the macrophages are gone, what comes after that? How about blood vessels for organization? And what comes after the organizing blood vessels? And actually it starts with the organizing blood vessels, are the fibroblasts. That would be a great question. Neutrophils, macrophages, endothelial cells, and fibroblasts. In that order. That is the evolution of the saga of cellular changes in myocardial infarct. Neutrophils 1 day, macrophages maybe up to about a week, organizing blood vessels perhaps a little bit after that, and then fibroblasts usually several weeks to several months to several years, because healed infarcts are usually scars, primarily fibroblasts. Okay, we're done with that. You're still with me. We'll cut this short And I'm going to show you something else. I'll just show you one more case because I know you've been working hard and I don't want to keep you overtime. So in this last case, once again, I don't have to convince you, but we could go on high power. You know this is myocardium. You can see there's a big subepicardial artery. You could see the fat. And you could see that there is not really a totally uniform pericardium, but it looks like that pericardium, for example, may be infiltrated with cells. So what do you call a pericardium that's infiltrated with cells? You call it a pericarditis. What if it was primarily neutrophils, like you see here? Would you call that acute or chronic pericarditis? Well, you know you'd call that acute. But let's show you even something more interesting. Not only is this an acute visceral pericarditis, and you're starting to see a lot of fibrin. You see the fibrin now? All this red stuff is fibrin. Not only do you see fibrin, but look, not only do you see a lot of fibrin, but you see a lot of dark black. It's almost like a vegetation on a pericardium, just like we saw vegetations on endocardium. So what do you think is the cause of this pericarditis? Virus, bacterial, renal failure, or rheumatic fever? Yeah, this is bacterial pericarditis. Usually staph or strep. Okay, we're done. Thanks for your attention. I'm glad I didn't have to start into a whole new chapter. So we'll just say this was the very last day. If Dr. August would like to say something now, if she wants to plug in her phone and just say goodbye or hello or I hated this or I loved it or whatever you want to say, you can. Otherwise, I hope that you come back, Dr. August. And we really loved having you here. And you can see from the comments now is that our buzzards, I call my students buzzards, they enjoyed us having you with us today as well. Okay, I think we're done. We'll close the lab. We'll go back to the main screen. And what we will do is play Raggy Mohammed's last song as a closing. And I'm going to give you the lyrics to it first because it's a beautiful song. And I don't think it's an Arabic song. It sounds like it might be a classic American sort of rock song, but it's a beautiful song. And I'm going to start it right now. It's called My Immortal. By the group Evanescence.
I'm so tired of being here, suppressed by all my childish fears. And if you have to leave, I wish that you would just leave. Your presence still lingers here, and it won't leave me alone. These wounds won't seem to heal. This pain is just too real. There's just too much that time cannot erase. When you cried, I'd wipe away all of your tears. When you scream, I'd fight away all of your fears. And I held your hand for all of these years. But you
Rock on, you buzzards. See you in 5 days minus 2 hours. Bye-bye.